He's the Steve Jobs' brother. Okay. But he was a Syrian. He was not an Egyptian. Steve Jobs was a Syrian. Steve Jobs was a Syrian guy. If you follow his ancestors, they were Syrians. So he was not from Egypt. So you cannot be his brother. You cannot be his brother. You said I'm his brother.
His biological father.
Okay. Okay guys, today what we are learning about the flexor compartment of the forearm, the anterior compartment or the flexor compartment of the forearm. As usual, I like to start with a summary. So in this we had the muscles, and what they do, they work on the wrist and the digits, and they are pronators. Their nerves are median nerve, and there is a little bit exception. Median nerve, and it's a deep branch, and we had contribution from the ulnar nerve that supplies 1.5 muscle, and the artery who supplies here is the profunda. So we have radial and ulnar arteries. They are contributing in the forearm. Now anterior compartment, for convenience, I divide it into 3 layers. Your books may write 2 layers. These layers we made for our convenience. Actually there are no layers. They are on top of each other. But to make it easier, to make it convenient, we name these layers. So if your book is a little bit different, that's not a big deal. So my first layer has 4 muscles. Out of these 4, 3 are supplied by the median nerve, and 1 of them is supplied by the ulnar nerve. The second layer, there is only 1 muscle who is supplied by median nerve. And the third layer, which is the deep nerve, that is not supplied by median nerve, but that is supplied partially by ulnar nerve, and the main contribution from a branch of the median nerve. And that branch of the median nerve, which is a deeper branch, because these are deeper group of muscles, so that branch is known as, this is anterior compartment, so that is known as anterior interosseous nerve. Like we learned yesterday, posterior interosseous nerve. That was the deep branch of the radial nerve. So deep branch of the median nerve is given the name of anterior interosseous nerve. Is that clear so far? Now going further, let's start building up these muscle layers. For our learning purposes, some area is very important, and that area who's very important is this medial epicondyle. Medial epicondyle is the main source for the flexors of the forearm. Now, superficial layer muscles, as I said, they are supplied by median nerve with 1 exception. And now these muscles are emerging, as I said, from the medial epicondyle and partially from the ulna, the first muscle. This small muscle goes to get attached over the radius. We call it pronator teres. It has, as it's been written here, one head is coming from the humerus, and one head is coming from the ulna. So that is a humeral head, and it has an ulnar head. Now this muscle, between these 2 heads, we had a nerve who's passing, and that nerve is what? Median nerve. So now, if there is a problem with this muscle, that muscle, if it hypertrophies, so that muscle will cause entrapment of this nerve, and this entrapment of this nerve will cause problem, and that entrapment is famous with the name of pronator teres, like median pronator syndrome is the name for the entrapment of median nerve. Now what is happening? As I told you, the nerve don't require too much heavy pressures. So a little bit pressure on the median nerve when it is passing between the two heads of pronator arteries, if they are enlarged, they are showing any pathology, that cause significant pressure, and that we call it as the pronator syndrome. Going further, we had a common attachment site, a common flexor origin, and that is to be attached over the medial epicondyle. And from this, now we have to bring 3 more muscles. As I said, in my superficial layer, we had 4 muscles. One we have seen and we have discussed. The remaining 3 muscles are from this common flexor origin. One is going towards the radial side. It's a muscle of flexor compartment. It crosses the carpal bones. It goes to the radial side. Can I call it flexor carpi radialis? Easy? Why we name it flexor carpi radialis? It's a flexor. Crosses the carpus, going to the radial side. You may ask me why I didn't put it on the thumb. That is more radial. Because if it was going to the thumb, then I will not be able to call it flexor carpi radialis. Then probably I could have been calling it into flexor carpi pollicis or flexor pollicis, because the thumb is an English word, but the anatomic name of the thumb is the pollicis, and anatomical name of in your foot, the big toe, is the hallucis. So word pollicis for the thumb. Anything which goes to the thumb is given the name of pollicis, and anything which goes to the other side, so that's why it's going towards the radial side, we call it flexor carpi radialis. Make sense? This muscle is innervated by median nerve. Clear? Now this is going to the second metacarpal. We all know that. There is another muscle which is coming down, and it has gone it stays in the middle. It stays in the middle, it doesn't go to any bone. It goes to a triangular area which lives in our palm. This is our palm. There is a facial sheath that is attached under your palmar creases, these lines. So that is basically this muscle which is seen in the middle is controlling that facial sheath. It's not going to any bone. It is going to a facial sheath. So this is going to the palm, and this is palmaris muscle. It is long one. We call it palmaris longus. Around 25% of people don't have this muscle. 25% of people don't have this muscle, but it doesn't mean they will have any problem, because that sheath is there. Only its job was just to strengthening up that sheath, so there were other factors, so it may be absent, and where it is going to this triangular area that we call as palmar aponeurosis. And palmar aponeurosis, this muscle is going to be attached on this palmar aponeurosis. This palmar aponeurosis provides us a pad. Once we are doing some activity, it's not happening, that activity, that force will damage our muscles or damage our nerves or damage our arteries. So this is a protective sheath, this is a protective layer, and that is preventing all that. Is that clear? So we call this muscle as palmaris longus. Yes? This all is here. We are talking about, look at my hand, we are talking about here. We are talking anterior, we are not talking posterior. This is in your hand. Now, I have another muscle that is going on the ulnar side, that is flexor carpi ulnaris. And now this ulnaris, its nerve supply is through ulnar nerve. This is the only one from my superficial layer which is not supplied by median nerve, but this one is supplied by ulnar nerve. Is that clear? So there you can see that it's going to the base of the fifth metacarpal and to this small carpal bone here, pisiform bone. Pisiform bone is an example for a sesamoid bone. What is a sesamoid bone? A bone which is made under the tendons and is because of friction, wear, tears. Now, there you are looking at an artery, which were here. We call it brachial. When it reaches to the head of the radius, it bifurcates. And you are looking at its radial part. Because this is the radial side, this is the thumb side. So this is the brachial artery, which becomes the radial artery. And we know that brachial artery divides into radial and ulnar. And where is the ulnar? You can see that it's going behind the superficial part of the muscles. So it is hidden. Is that clear? Any questions so far? So we call it ulnar artery. Now what is that? Ulnar artery visible. Here under the muscles it was not visible, but you can see that it is passing across these tendons. Guys, the relationship of ulnar artery and these tendons are important. We target this question a lot in our exam situations. So be ready for that.
What do you mean?
Should I tell you the question?
No, but you mean the position of the artery
Between these tendons. You might be given a situation, is it medial to this, lateral to this, or lateral to this, medial to this, above to this, below to this. So you have to be very specific for this, where it is present. Like one of the question you guys had in your TBL last week, and you had a concern with that question. What was your answer? Someone stabbed in the back and unable to abduct his shoulder. Deltoid was the answer. So who put deltoid as an answer? And who put supraspinatus as an answer? So now you put supraspinatus as an answer. Can you tell me why? Hold on, let them say. Anybody who's raised hand for supraspinatus?
It's the middle fibers of the deltoid which do adduction.
Okay.
And we have an injury to the posterior thoracic wall.
Yes.
Where the supraspinatus lives.
So this is your concern. Anybody can support him? Anybody have any different opinion? Osama, you want to talk in favor of supraspinatus or you want to talk in favor of deltoid? Supraspinatus. So tell me your point. Okay. No. Give me an answer. Don't say nerve of this is whose nerve is in the back. Supraspinatus or deltoid? Whose nerve is on the back? Not depending. It's there or not there. Your nose is here. You cannot say my nose is on the back. Your nose is on the front. So whose nerve is on the back? Deltoid or supraspinatus? Deltoid. And the question says someone stabbed with a knife on the back. I cannot write someone is stabbed in the quadrangular space. Someone is stabbed in the back. It was not said in the shoulder. On the back there is only one nerve. Tell me any other nerve there which is related to your brachial plexus. So once axillary nerve is cut, axillary nerve is damaged, who should be involved? And the clue was unable to abduct above the shoulder. It means trapezius you could have bring, but trapezius has little bit other function. So it was deltoid. Make sense? Clear? So those who are writing supraspinatus, it was not injury to the deltoid. It was injury to its nerve. Once nerve is gone, that function is gone. So this was a baby question. So prepare for questions. We are treating you now adults. Nobody is minor here, I can see that. Everybody is an adult. So come prepare to be an adult. Got it? Is it clear so far? So this point is important. How it is important? I gave you the clue. Now you have to figure out. Now what is happening? I am seeing some nerve here. We talk about it. Who's this nerve? Ulnar nerve, and you can see now it's emerging somewhere down as well. Is it clear? Now you can see there are more relationship between ulnar artery, ulnar nerve and the tendon of flexor carpi ulnaris. Okay? Injury to the common flexor place, origin, medial epicondyle. What it should be known as? Ayman taught you this topic in detail. So we call it Golfer syndrome. Right? So primarily the injury was to the medial epicondyle, and anything which is emerging from medial epicondyle is affected. So the problems are there. One, the opposite side, the lateral epicondyle, if you have injury there, that is a tennis elbow. Previous year, we put an SAQ on tennis elbow. I like to hear from the horse's mouth, those who took it. Tell me, how was that question? And what was the overall response of your class for that question? Siri, tell us. You took that question. It was there in your MSK exam, final exam.
I didn't test.
You didn't?
I didn't.
You did.
No.
You did. But how was the feeling of your class for that question? It was a very easy question, but it was written with a style, and everybody was engaged with this question. There was a big hue and cry for that, and a big number of people was unable to do it right. So please, these are the things which are very clear. We emphasize a lot. We are overlapping. My friend has taught you. I'm talking on it again. So please be ready with these things. Nothing new. We don't bring anything from our home. All the things which has been taught by any of us will be part of your exam. Right? And be ready with the things. Only, trust me, if you use your brain little bit, there is nobody can stop you from scoring 100% marks. Going further, so what is happening? Inflammation and injury, this has been dealt, so I'm not going in their details. So now, as I told you, anything important for a muscle is its function, action, nerve supply. Here the life is very easy. These three. The one is, it pronates and flex the wrist. And these muscles, their prime function is, what they are doing, they are pronating the forearm and they're flexing the wrist, because they are just crossing over this joint. The main action is being brought here. And palmaris longus, that is all for this palmar aponeurosis. Easy or difficult? So any of these muscles, you can put these actions. Clear? Any doubt? Nerve supply is one, that is median nerve, except for ulnaris, that is ulnar nerve. Right? Now, going further, the middle layer, intermediate layer, the nerve is median. You are looking at ulnar nerve. Here is my beginning of this only muscle. That is, now see what happened. I have covered my ulnar side, I have covered my radial side, I have covered the skin of the palm, the aponeurosis of the palm. I'm left with the digits. So I need some muscle for the digits. Obviously. But flexor digitorium is not the name. There are two muscles here with this name. So, and if you say flexor digitorum, never say that. We have extensor digitorum. Flexors are two. So we put some extra words for them. So this one you're looking at in the intermediate zone, this is nothing but flexor, which is for digits. It is for digits, so flexor digitorum. But it is superficial. Because I have a deep one also. So I like to call it flexor digitorum superficialis. Please don't write FDS or FDP. In the exam, when you're writing, write complete. Flexor digitorum superficialis. So this muscle, you can see that it's emerging from medial epicondyle. It's coming from front of the upper shaft of the ulna, front of upper shaft of the radius, and then this muscle when it reaches in this segment, there it gives its tendons, and each tendon for each digit. So this hand is coming from the humeral end, and this is from the radial end, and all of them are dividing into 4, and each one is dividing into 2, and they are getting attached to the bases of the middle phalanx of the hand, middle phalanx of the digits. Remember, we don't have middle phalanx in the first digit. We have second, third, fourth and fifth digits, they had middle phalanx. Clear? And it splits and then it gets attached. Clear? Its nerve is the median nerve. And what its action should be? It crosses primarily the main bulk of the muscle through its tendon. It crosses carpal joint, wrist joint, carpo-metacarpal joint, interphalangeal joint. So I can say this is the flexor of. So this muscle, flexor digitorum superficialis, I'll come to its action. Here again we are looking at brachial artery and radial artery, and again we are looking at ulnar artery, and now you can see that still ulnar artery is under my flexor digitorum superficialis. Coming down, it becomes evident here. So now it's lateral to its tendons, but it was medial to the other tendon. So it was in between. Clear? Now you're looking at this nerve, median nerve, and now what's happening? Before it was on this side, now it deviates. It comes towards the radial side. It was on middle, it moves to the ulnar side, then it deviates to the radial side. So the nerves and arteries, they may cross their pathway on their way when they are reaching somewhere. It can happen. So this is median nerve, just lateral to flexor digitorum superficialis near wrist. So you can, this can again be a question. So now this is the ulnar nerve. Now what it does, it flexes the wrist and digits 2 to 5 at metacarpophalangeal and proximal interphalangeal joints. Right? If you don't put this much action, you just say flexor, you'll get maybe quarter of the mark, 0.4 out of 1. If 1 mark is the answer, total answer. So our key goes like that. Clear? Going further. So deeper layer. Now the nerve is not median nerve. The nerve is anterior interosseous nerve. It's deep branch plus ulnar nerve. There I have a small muscle who has 4 angles. I call it pronator quadratus. Name says it's a pronator. Second, what it does when you're doing push-ups. I hope you know what are push-ups. When you're doing push-ups, it prevents radius and ulna not to be separated. Interosseous membrane does that work, and this pronator quadratus assists you in that action, that damage should not happen. Yes?
You said it has 4 something along the way?
4 angles. Quadrangular. Pronator quadratus. 1, 2, 3, 4. Okay? Pronator quadratus. Now we will review the arteries and the nerves in the forearm. See what happens to them. We learn about this brachial becoming radial, and then giving ulnar. This is a normal thing which we have seen, which we have done. Now, the main artery in the forearm and in the hand, in the palm, is ulnar. So this ulnar artery, see here what happens. It gives a branch. That is common interosseous artery. Common interosseous artery. This common interosseous artery, it divides into anterior and posterior interosseous artery. Anterior interosseous artery comes in front of the interosseous membrane, supply in the anterior compartment. Posterior interosseous artery pierces this membrane, goes behind and supplies in the extensor compartment or the posterior compartment. Nerve Posterior interosseous nerve was a branch from radial nerve. Anterior interosseous nerve is a branch from median nerve. But anterior and posterior interosseous arteries are different. Both are branches from ulnar artery through its common interosseous branch. So there you can see common interosseous gives anterior interosseous. And then it gives posterior interosseous, which goes behind the interosseous membrane. And they are responsible to supply anterior and posterior compartments of the forearm. Is that clear so far? Now, there we can see who's this nerve coming, median nerve, and then this median nerve giving its anterior interosseous branch. And this is my ulnar nerve. It crosses behind the medial epicondyle, comes down and supply on the ulnar side. Clear? So now here, flexor digitorum. Now these tendons have shown to you. I have not put here flexor digitorum superficialis because my subject here is the deep muscles. So now, and pronator quadratus, what it does, I explained to you already. It pronates plus it prevents the separation of radius and ulna.
Median nerve doesn't divide into a posterior interosseous nerve?
Median nerve become anterior interosseous nerve, separate. Don't mix with the artery. Ulnar artery gives posterior interosseous artery and anterior interosseous artery. So posterior interosseous nerve and anterior interosseous nerve are two different things. And anterior and posterior interosseous arteries are two different things. Clear? So now, there is my flexor digitorum profundus. You can see it is not coming from medial epicondyle. See, all deep muscles are not engaged here. They are totally confined to the forearm. It's coming from the front of the ulna, from the interosseous membrane. It goes down and then it splits in 4 tendons. And these tendons, they pass through. What is happening? This is my flexor digitorum superficialis. When it reaches to the middle phalanx, it bifurcates like this. And flexor digitorum profundus tendon, it goes through it to reach to the distal phalanx. So it has, if flexor digitorum superficialis can come and attach like this, how profundus can go further? So it makes a space for that, and through that space, through that bridge, the profundus tendon is going forward. Is that point clear? Any question?
So you said it goes to the middle of the phalange. What about the thumb? Okay, I understand this argument, but how does it work?
Who?
The thumb.
Just wait. I will explain you later, not now. Flexor digitorum superficialis. When it comes, when it's to be attached, this is my middle phalanx. You agree? This is my middle phalanx. It's attached on the base of it like this, by splitting in 2. And profundus tendon goes through it. Because how it will reach to the distal phalanx? Now I want to check my profundus is working or not working. How I do it? Can anybody demonstrate to me? So you have to stabilize. Perfect. You have to stabilize flexor digitorum superficialis. Otherwise their functions are overlapping. So you have to stabilize it. You stabilize it. Now flex the distal phalanx. Can you do that? So it means you checked that profundus is working. Check here, profundus is working. Check here, profundus is working. It's working everywhere. You may do without that if it is stabilized. So profundus is being in work. It's flexing the distal phalanx. This is the action of flexor digitorum profundus. Clear? Now flexor digitorum profundus, for my pinky and my ring finger, this half is supplied by ulnar nerve, and for my ring and my index and middle finger are supplied by, don't say median. Don't say median. Say anterior interosseous. If you mess up with this, you can be in trouble. The exam key is anterior interosseous. If you say median, I understand is a branch of, like a series. Today you have big problem. Right from the beginning, he has problem. Discussion, take him outside in Kudo and feed him and discuss what he wants. He likes that. Otherwise, take him to a better restaurant. So, remember, if someone asks me, what is the blood supply of my radial side of the hand? I can say heart. Is it wrong? But once you are asked, you are expected to be specific. To be specific, you have to come to the point. Got it? So, flexor digitorum profundus, we talked about it, medial half ulnar and lateral half by the anterior interosseous, which is a branch from median. Clear? Now we talked about how the tendons are going through each other. And the actions are now, it flexes the wrist, digit 2 to 5, metacarpophalangeal, proximal interphalangeal and distal interphalangeal joints. So all the interphalangeal and metacarpophalangeal joints have been flexed by the action of flexor digitorum profundus. Is it clear?
After the nerves on this ulnar nerve and anterior process.
See, ulnar nerve give two branches for fifth and fourth half of the flexor digitorum profundus. And there you can see from anterior interosseous for 2 and 3. For 2 and 3 from anterior interosseous, for 4 and 5 from ulnar nerve. Clear?
The superficialis, are the fourth and fifth digits all by the median nerve or also the ulnar nerve?
4 and 5 ulnar.
Superficialis too.
No, superficial is all by the median nerve. That's why when you have injury to the median nerve, you have hand of benediction. Because two are not innervated, those who are innervated, like injury to the median nerve, so still flexion is shown. But here flexion is not shown. That is your hand of benediction. Extensors are more dominant. Got it? So action of flexor digitorum. So can you understand? Median nerve injury, the ulnar nerve part will still flex. And ulnar claw is a different thing. We'll talk about it. Is it clear so far? Now I have another muscle for my thumb. That's coming from the front of the radius and it goes to the thumb first. So we call it flexor pollicis longus. Why I call it flexor pollicis longus? Because I have a flexor pollicis brevis as well. So it's going to the base of the distal phalanx. So guys, when we talk of nerve, this is minimally required. Median nerve, 5 to T1. No branches in the axilla. One small branch to the brachial artery in the arm, not to any muscle. Then in the forearm, so many, and in the hand, so many branches. This is minimally required. And if you don't know this much, so injury here will have some other effect. Injury here will have some other defect. Injury here will have different effect. So wheresoever injury, beyond that, the area is damaged. So this is for ulnar nerve, same distribution. So I have given you 3 now. Radial is given, ulnar is given, median is given. Remind me, I will give it to you, musculocutaneous and axillary also. Now, a little bit concept, how these tendons which are in the hand have been controlled. So, there I have my metacarpal, proximal phalanx, middle phalanx, distal phalanx. Now here I have the extensor tendon of extensor digitorum. This is attached to the distal phalanx. On the extensor side, we don't have superficialis. So now, this tendon, how it stays in its, you can see on your hand, these tendons are visible. These tendons are visible on your hand. On the dorsum of your hand, these tendons are visible. Now these tendons, how they kept in their position? We put a cover on them, and that is attached on both sides of the bone. That is known as dorsal digital expansion, extensor hood. So that stabilizes this extensor tendon, extensor digitorum tendon. Now we learn that this was my flexor digitorum profundus, and this is my flexor digitorum superficialis. Can you see? It overrides, and profundus goes through it. Now how it is stabilized? It is being, because they are going so close, so there is a chance of friction, chance of wear and tear. So they are provided a synovial sheath. Like your joints have synovial space, synovial membrane. So there is a synovial fluid inside which minimizes the friction, which gives the freedom of movement. And now how to fix it? To fix it, we have some straps. They are overwrapped. They are annular, rounded, and they are also in a crisscross fashion, cruciform. So these are digital sheets, fibrous digital sheets. On this side, we had these fibrous digital sheets, no matter annular or cruciform, and on the dorsum, we had dorsal digital expansions. Their main function is to keep these tendons in their place. They should not be moving from their right places. Is that clear? Any question?
Is the cruciform portion inside the sheet or outside?
Obviously, what it is doing.
Outside.
If I want to fix a cable, my clip should be inside or outside?
Yeah, like that.
Now, if any inflammation of a tendon, we call it tendinitis. If there is an inflammation of the synovial sheath, we call it synovitis. And if there is an inflammation of both, we call it tendosynovitis. Will you remember this? Tendosynovitis. What is synovitis? What is tendinitis? You know it. Now, what is happening? What are these images? These images are about compartment syndrome. What happened? Someone has a fracture. Someone has a burn. Now, what is a muscle by nature? Osama, muscle is what? If I take chemically, what muscle is made up of? Protein. Simple? So protein. You denature protein. Egg is what? Protein. You boil an egg. What happens? A fluid becomes solid. A solid ball. You can hit someone. Little bit. You cook a muscle. It becomes solid. So once you have a burn, your hand is got burned. What will happen to your muscle? Think. They will be cooked. They will be swollen. You have some injury. There is an impact of trauma. There is swelling. So once there is a swelling, we know that these muscles are wrapped so tightly in a sheath. We call it deep fascia, which never allow these muscles to get, like you all are in this room. If I put 500 students more in this room, what will happen? At least 50 will die of stampede. They will be crushed. Because these walls we cannot push. So think, in any compartment, in the arm, in the forearm, in the leg, in the thigh, muscles are wrapped in deep fascia. If there is any denaturation inside, these muscles will expand. These muscles will expand. There is no room for expansion. And in between these muscles, we have nerves and arteries and veins. So they will be compressed. Once these nerves will be compressed, you will have pain. Once these vessels will be compressed, the supply to the hand will be gone. Blood is not going. Blood is not going means oxygen is not going. Oxygen is not going, hypoxia. After that, less oxygen. A time reached, no oxygen, anoxia. Then you had necrosis. then you had gangrene. The hand turns blue and ultimately black, and the answer is chop off, non-reversible. You tie your hand with something, see that your hand turns pale, hypoxia. Leave it for 24 hours. It will be turned blue and black. You have to cut it off. Nobody can revert it. So, once that is the situation, after fracture, after some bruised muscles and some crush injuries and all that, some burn, we have to act immediately. We have to split this deep fascia. We have to take a knife, just give incisions across the affected parts on the body. If you don't do that, you will see that dead body parts. So you have to make these splits. You have to expose the muscle. Your incision should go till the muscle, where muscle starts appearing up. It means you have damaged, you have cut, you have chopped the deep fascia. Now these muscles are relaxed. Muscles are relaxed. The structure which are going in between these muscles, they are relaxed. So it means supplies continue. Pain is less. Pain is gone. Blood supply is continuous. The distal parts get oxygen. Venous return is there. Everything is functioning. So if you don't react like this, it looks barbarian. It looks weird. But if you don't react like that, you can see someone losing his body parts.
Isn't denaturation of a protein irreversible? So how would the muscle go back to its original size?
Look, damage has occurred to that muscle. Makes sense. Now you want to damage the whole body? If you have a problem here, you take an apple. It has one small black spot. Your whole apple is bad? You chop off that part and rest is fine. No need to take out the muscle. The muscle who's bruised, I'm not saying is cooked. The muscle is bruised, have a chance to heal back. Obviously once it's cooked, nothing is happening. But once it's partially cooked, when you are burned, nobody grill you there. You put some hot water on your hand, some steam on your hand, that burns little bit, that causes swelling. After some trauma, you had some swelling. Do you?
Yes.
So that cause, if the trauma is inside, that cause expansion of that muscle. When this muscle is expanding, there is no place to expand, so it causes pressure onto the structures who are going in between. Are you with me?
As you said, take off the muscle. Got it?
Why?
You said take a knife.
This is what I said? Man, can you play recording for him? It shows he was not here. You were cutting deep fascia, that's it. What's it? His muscle is cut? Man, recheck your vision. You need badly. Yesterday you are not able to do it. Today you are not able to do it. Mushkila. Now, or sit here.
How long does it take before the muscle deflates?
Now,
You can't keep the fascia.
it's variable. He's a child, he's a young person, he's an athlete, he's an old person, he's a diabetic, he's an hypertensive. Different condition, different timeline. Type of injury, type of chemical exposure, steam, some injury, crush injury, blah blah blah, variables.
So the entire time the skin's open.
Skin is open, but you don't let him go and walk in Vatha. You cover it, wrap it, keep him in hospital till everything goes fine. Now, we split it, we put these clips so that it's partially closed, but you can see it's open. So there's a room for expansion. And they put these rubber bands, so there is a chance for expansion. You didn't apply end-to-end sutures. You didn't apply end-to-end clips. You gave these rubber bands, so you are providing a space because you don't want to leave this wound open for long. So you put this way, you do it this way. You put these rubber things and you put these clips, they are anchored, but there is a chance for expansion. If there is more demand, there is an expansion which is possible. We are not putting steel wires here. We are putting rubber tubes here. Clear? Now, this is a tool which is helpful. when you are suspecting someone having compartment syndrome. Insert this needle in, you get a reading here, you get the pressure here. What is the pressure inside? So it's not necessary you chop off everyone. You have the tools, you have the gadgets, use them. They will be helpful. Clear? Now, coming to a very important concept. I made a section at the level of the wrist. Look at my hand. The wrist is being cut here, chopped, and you are looking at a cross section of the wrist. Skin, superficial fascia, and the fibrous bands and the carpal bones are visible. This is anterior, this is posterior, this is lateral, this is medial. Right? Now, the bones, let's label them. Number 1, hamate. And this process of hamate is hook of hamate. Capitate, trapezoid, trapezium. Right? Now these are all extensor tendons with their synovial sheets. I have shown you one example of a synovial sheet. Now there start appearing some other structures on the anterior side. Flexor carpi radialis. This is another muscle, flexor pollicis longus. And these are flexor digitorum superficial, flexor digitorum profundus. Now there is some pad is being provided, some sleeve is being provided, so that each of these tendons, they can work without problem. So this is on ulnar side, so we call it ulnar bursa. Okay? It facilitates the freedom of movement for these tendons, extra freedom. Yes?
How come that gives
My dear, you're looking at a cross section. You're not looking at a vertical section. Got it? You can feel it. The hook of the hamate is palpable here. Now what happens? This is my median nerve. There is something wrong. Who is this? This is the deep fascia. And now the deep fascia becomes very thick, like the strap of your watch or your bracelet. So this thickening of deep fascia, the function of this, keep every tendon in its position. Extra protection. So this deep fascia, who thicks out specially, we give it a name. We call it flexor. It's on flexor side. We call it flexor retinaculum. Another difficult name is there if you want to enjoy difficulties. But simply remember flexor retinaculum. Is that clear? Now, people have problems. Not everybody. Those who are affected in their certain situation. Let me complete it, then I'll come to the situation. This is a branch, a cutaneous branch of median nerve. There is ulnar artery and ulnar nerve. So median nerve, before entering in this, before passing under this flexor retinaculum, it gives a cutaneous branch. Now what happens? There is my radial artery. Who is this? Anything who is superficial. Above the retinaculum. Palmaris longus. Tendon of palmaris longus. Clear? Now what happens? This space, before this was here. Now some fluid has come here. And that thing caused this space narrow. The flexor retinaculum bulges out. Every structure is being pushed upwards. So there is a problem here inside. There is some fluid accumulation. Various conditions. Pregnant women have this problem. And those who are secretaries, typists and all that, they are suffering from that. They have special type of keypads for them. They are designed for their health. They have some cushions they keep under their wrist when they are typing and doing their work. Women are mostly affected. Now once this area is congested, zahma, this area is congested, all these tendons are under compression. Their movements, there will be difficulty in movement. Don't think you can go like a robot. No. You have movement. Muhammad is sleeping today. Muhammad, I'll ask while Dahan bring a bed for you. Because don't break your laptop. Huh? So, what happens? Everything is compressed. So these movements become painful. Look for an housewife who's making food for her children. And now she has to move her fingers, move her hand. Now she cannot. She has difficulty in movement. Because this median nerve is compressed. And all the muscles who are innervated by this median nerve in the hand, they are under problem. They are an issue. Right? That condition is known as carpal tunnel syndrome. The severity of the pain is so bad that ultimate option is a surgery. No medicine resolves this thing. You cannot aspirate this fluid out. Even pregnant women in their time of pregnancy may become victim of this problem. So the treatment is what? Open the skin, just split this flexor, just make a cut in that. Open it, finish, and then put the skin, sew it, get out. 5 minutes job. Patient is comfortable, relaxed, thankful for you to rest of your life. So you release the pressure. You release the pressure, problem is solved. Got it?
What's the relationship between pregnancy and the
This is the topic. Last year we did a journal club for the students. They came prepared. They were given different tasks. Let's see this year. Go and Google it. So median nerve being compressed by the fluid built up. You see that. Now, finally we reach to some challenge part, some interesting part. So here you are looking at what? What's happening? There is a fracture. Where? Dislocation? Let, no. Today is not happening. It was yesterday. No, it looks like, I agree with you, but it's not. It's just overlapping. So the radius, the distal fragment of the radius got fractured, and now the radius shaft is overlapping its distal fragment. It's crossing over. It looks, because if it was impacted, Muhammad, it could have been seen going inwards. And there, when something goes inward, there must be some cracks on these sides. So there is no such thing. So it is overlapping. And this distal fracture of the radius is very common when people fall on their outstretched hand. It's a very common type of fracture. Is children have on the clavicle. Adults have on this. Child have a fall, have problem with supracondylar. Adult has more problem here. Older people worst here. Athletes, sportsmen, all those. Yeah, perfect. Nothing happening. Only when this segment is distorted, there are little bit changes. So now, this change is familiar. It has a name to it. It resembles something. So this was the bony fragment. This was the original position. This was the distal end of the radius. Now, because this end is been overlapping, so it has been moved to this position. Can you see that? So this end, it has to be here, and it has to be pushed forward, but it has moved backward. So lower end of the radius is being pulled, going over the distal fragment. Can you see that? Now this white thing has moved to this red place, and it looks like this fork. We call it a common term, layman term, dinner fork deformity, and scientific term, Colles fracture. This is a classic. Distal end of the radius got fractured, not the ulna. Obviously there are so many things. Now, tell me, Mohammed, what's wrong here?
is an image fracture
Of
carpet.
which carpal bone? Shh. Which carpal bone? Are you Mohammed?
I don't know.
Okay. So first, do you agree there is a fracture? Everybody can see that? This is the fracture site. And this bone is known as scaphoid. It's a very common fracture. It occurs usually along with this distal end of the radius. And this fracture is very bad because once it happens so many times, X-ray cannot show this fracture. You need to have very different type of views. Then you can pick up this fracture. And sometime you do an X-ray, an athlete fell down during play, pain is there, they put some pain relief, they do an X-ray, X-ray is fine. Patient is sent home, okay fine, just put this thing, it will heal and all that will happen. But now the problem emerges when the pain is getting worse and worse and worse. So worsening of the pain is not the issue. And this worsening of the pain is in one typical place. If you go to your wrist and you extend your thumb like that, there is one space formed here. There is one depression formed. You can do it. Check yourself. You can see there is some space formed. This space is given the name of anatomical snuff box. And this anatomical snuff box was used in old days for a purpose. And even today it is used for a purpose. Anybody have an idea of what was the purpose?
To sniff.
No, not pulse.
Medical purpose.
Medical purpose or does not work?
To sniff.
To sniff what? Cocaine. Mukhaddarat, don't touch it. People put cocaine here, sniff it. Don't try it, otherwise you'll become high. So medical purpose is not, the mainly is famous for, we call it anatomical snuff box. It has its boundaries, you need to know it, it will be part of your OSP exam, be ready with that. So this bone is making the base of this anatomical snuff box, it's there. But why I'm saying this fracture is very bad? Because, do you have any idea why this fracture is very bad, Mohammed?
This fracture is very bad.
Yeah.
Because the main reason why we can't move
No. Even if Coley's fracture happens, you cannot move your wrist. If other carpal bones, guys, if other carpals have gone, you don't have a same problem. So, but I want something different. You want to say something different?
Yeah, I think surgery is radial artery.
Yeah, for a long time because blood vessels pass.
Huh?
Because blood vessels pass through it.
So what happens?
So there's a fracture, there might be a rupture in one.
Now, don't Google it, my dear. Come here. Now see this. This is an image of a carpal bone. How it look like? Can you see these openings? The arteries, the nutrient arteries go through these holes. If this bone is fractured here, all is fine. Because blood supply goes to the upper part, blood supply goes to the lower part. But if fracture occurs in the lower segment, there is no blood supply and there is no internal connection. So this part remains unattended. You spend 5-6 days, this becomes no blood, no oxygen, ultimately it becomes necrose. And then it becomes black. You have to take it out, surgical intervention is required. It's a bad news, all that, and that will interfere with your functioning and all that. But the main thing is, this part is never reversible, it goes necrosed. Obviously, if you anticipate it early, you can start treatment early. There are chances for salvage and for all that, for safety and protection and all that. But if you miss this, usually why I'm saying you miss this, so many X-rays cannot show you this fracture. Only patient is sent home, he is visiting you after a little bit, week after, doctor, still I have a severe pain. Now you start thinking why the severe pain is there. There is no obvious bony injury, the ligaments are fine, the tendons are fine. Then you redo X-ray and then you find, or you send him for CT or MR, there you find there was a fracture in the scaphoid, and that has maybe resulted in the avascular necrosis. Avascular necrosis only occur in two types of fractures in our body. One is for the scaphoid, one in the lower limb, head of the femur. It can go into avascular necrosis, and there again the same problem is there. Now, the picture which is showing you the fracture, the distal end of the radius is there, and the shaft of the radius is going down. It is lifted upwards, and showing also the scaphoid fracture. Now, who can answer me why this distal end of the radius is not going downward? Who keep it upwards? Why is it going upwards, and why this is downwards? Anybody else? Nizami? So? Mohammed? Who is that? Who is that? My question is, this distal fragment is staying in its position, rather is more up, and then this bone is gone drop down. So who's pulling it up? Anybody else?
The pronator quadratus is keeping it.
Nizami comes with pronator quadratus. Any idea? Anybody else? Tariq. No. No. Guys, give a big hand to Osama. Your answer, brachioradialis, was the right answer. If you remember, brachioradialis was coming from this lower part of the humerus, and it was going to get attached to the distal segment of the radius. And this attachment is there. Now this bone is now not engaged. Its bone is free. So it is being pulled upwards and backwards. You can see that. It is tilted. It's not like this before. It is tilted because that muscle is still there. That muscle is now free to pull it upwards. Before it was attached here, so it was staying in its place. Now this end is free, so it is being pulled upwards. Clear? Now, if you see that, this is the radius, this is the broken fragment, ulna, fracture place, scaphoid, and now the position of the hand goes, like I've shown you in my previous picture, like a dinner fork. So this is a typical, and like Mohammed was saying in the beginning, the median nerve is going so close to this sharp end, and it may involve, it may damage, it may transect completely the median nerve here. If it does, you had phantom phenomena. Can anybody tell me what is phantom phenomena? Mohammed, you talk about median nerve. You tell us about phantom phenomena. You started with this.
So probably the risk would be like we can extend the risk itself, but we cannot like close our hand.
Anybody else?
So you feel that the hand, if it's not there, you feel like it's still there.
Give a big hand to him. Someone, after an operation, a need arises, you have to cut the leg. The person don't know what is happening. He had a trauma, he had a severe accident, and when he opened his eyes after his surgery, he is asking his brother who's sitting with him, "Shh, can you scratch my foot?" And brother is, where is the foot? It is all cut. So the feeling of that hand is, or leg is still there, foot is still there, something is creeping in and saying, I have a pain in this leg. Leg is not there. I had a pain in this hand. Median nerve area supply thing. Median nerve is all transected. Still if you have a perception, that is the phantom phenomena. The structure is damaged, cut, gone, but still you have the perception that it's there. That's phantom phenomena. Otherwise, phantom is a very expensive car. You know it. So now, this injury is the issue. Now guys, I need your diagnosis. What do you think is that? Fine, minor's hand, very good. Mohammed says normal. Everybody says normal?
Small boy, still grown.
Tariq, can you show me the fracture? Come out and show me where is the fracture. Give a big hand to Tariq. So, look, this is a very typical, guys, this is a very typical fracture. Both of the cortical, nothing wrong in the cortex. Periosteum is there, everything is there. We call it a green stick type of fracture. It usually happens in kids, minors. Have you seen if you take a tree and cut a part of it, if it's a wood, you can break it. But if it's a green thing, you want to damage it, you cannot. It can be flexed, but it can re-go. So this bone is very soft. So it is happening, a green strip type of fracture is occurring, but it will not affecting the cortex of the bone. So in this type of thing, what we do at the end of the day, when these kids come to you, we break it. We complete the injury first. Because healing will never start. We need to break it and then we fix it, then it goes fine. If you leave it alone, it will stay and it will cause pain to this child. So this is called a green stick type of injury. Well, this is the method, Mohammed. Grow big, invent something new, and bring an in. Now the next slide, there you can see this this fracture thing. Now this is a very conceptual slide. What happened? Someone has broken his radius in the proximal part before the lower attachment of pronator teres. Now because biceps is our strongest supinator, so this part of the bone now it is free. It is supinated and it is pronated. So when you are fixing, and here it's all set. So in this type of thing, if you are fixing these type of fractures, there is a position described how you can keep. This is application part, don't do it. But only for you, why I bring this picture for you, because it is very important to understand if this bone is fractured before the attachment of this pronator teres. This, because supinator is a very strong supinator, it can supinate this fragment and this fragment will remain pronated. So if the bone heals like that, if you just put a cast, half is pronated, half is supinated, think what action will come, and then you will be in big trouble. So this is for your thought, this is a mechanism, and that is if you know it, fine, but if you don't know it, perfect. If you're targeting A, then you should know it. If you're targeting B, then it's fine. Don't know it. Got my point? This is a high-tech information. It's a concept. Is it clear? Any questions so far? We are done for today. Thank you for your, I was hardly able to finish with M1, but M2 people were quiet and sound. Today a little bit relaxed environment was there. Thank you, Mohammed. You are sleeping today. We were very comfortable.